some money associated with that. So now we move to session 3, and there are two rooms. The first hall will be the adult tract, Hall A, and we have chairs, Dr. Sami Azar and Tariq Nasser, and then the other hall, Hall B, which will cover radiology and nuclear tracts, and the chairs will be Dr. Abbas Mansour and also Hussam Al-Hawari.
Hello everyone, and it's my pleasure and honor to be chairing this session this afternoon, and to be presenting the first speaker to this afternoon session, Professor Paul Ladenson. Professor Ladenson is a professor of medicine at Johns Hopkins University School of Medicine. He's also a professor of oncology, pathology, and radiological sciences. His area of clinical expertise include thyroid diseases, endocrine and metabolic disorders. And his presentation this afternoon is entitled Subclinical Thyroid Disease. And I would leave the floor now for Professor Ladenson to present his talk.
Good morning. It's a pleasure to join you. Thank you, Mr. Chairman and meeting organizers, for inviting me to participate in this important regional conference. My presentation today, as you know, is about subclinical thyroid dysfunction. There's been some important new evidence over the past 5 years relating to this topic that has significant clinical implications. This condition is one I don't need to detail for this audience. Subclinical hypo and hyperthyroidism are defined by biochemical parameters, serum TSH concentrations beyond the reference range despite maintenance of normal serum-free thyroxine. And the entire clinical issue revolves around this question: do these minor changes in thyroid hormone level matter in any tissue other than the pituitary? Beginning with the more common of the two, subclinical hypothyroidism, its causes are really the same as those causing overt hypothyroidism. In the vast majority of cases, Hashimoto thyroiditis. It is important to remember that there are other causes of modest TSH elevation, as detailed on this slide, importantly, including recovery from transient forms of thyroid underactivity and non-thyroidal illness. It's also important in diagnosing this syndrome to recognize the age-related variation in normal serum TSH concentrations. As you can see in these data from our NHANES 3 study of 35,000 Americans, among those 80 years and older, the normal serum TSH concentration, as conventionally defined, can extend as high as 8 to 10 milliunits per liter. This is a very common syndrome. In these data from the Colorado Health Study, you can see it ranges from prevalences of 5% in young adults to as many as 1 in 5 women over age 74. The potential indications for treatment of this condition have been those shown here. Improving the quality of life, preventing progression to overt hypothyroidism, avoiding associated cardiovascular risks, and finally, the important issue of hypothyroidism in pregnancy, an issue that we're not going to address in today's presentation. So let's look critically at the evidence supporting or refuting these traditional arguments for treatment of subclinical hypothyroidism. This again from the Colorado Health Study shows you the prevalence of symptoms typical of hypothyroidism, the prevalence of symptoms in individuals who prove to be euthyroid or to have subclinical hypothyroidism based on their TSH level. And you can see that, and this is no surprise to any endocrinologist, you can see the lack of specificity of symptoms suggesting hypothyroidism. In fact, the positive predictive value for these individual symptoms in predicting the presence of hypothyroidism was only approximately 10%. So what evidence do we have that any such non-specific symptoms regarding energy, cognition, or mood will be benefited by thyroxine therapy? This older study by Parle describes a double-blind, placebo-controlled one-year trial of patients assigned to either placebo or levothyroxine therapy that achieved a normal serum TSH. And you can see a wide panel of neurocognitive and mood studies were administered to these subjects. Among the levothyroxine-treated patients, these investigators were successful in achieving euthyroidism in more than 80%. However, you can see here that this entire panel of cognitive testing failed to demonstrate any significant difference between the groups treated with levothyroxine and those treated with placebo, failing to support the concept that a hypothyroidism, subclinical hypothyroidism, is associated with reversible neurocognitive changes. In a study using another strategy, Professor Mary Samuels performed a randomized double-blinded crossover trial in a group of overtly hypothyroid patients who were purposely rendered subclinically hypothyroid by a levothyroxine dose requirement. And she too used a wide panel of cognitive function tests. As you can see, the induction of subclinical hypothyroidism deliberately produced no decrement in any of the measured parameters, except for one of the three tests of working memory. We're very fortunate that finally, within the past 6 years, we've had what we've long needed, a large prospective randomized controlled trial of levothyroxine therapy. This one, published in the New England Journal in 2017, describing a group of older adults in England and Europe administered either levothyroxine or placebo. These patients were more than 65 years old. Among the outcomes measured was a survey for hypothyroid symptoms, a quality of life score, and a tiredness scale. Patients were treated with levothyroxine generally in a relatively low dose, with a decline in the levothyroxine assigned patients from 6.4 to 3.6 milliunits per liter in TSH. And you can see, to the disappointment and surprise of many who have advocated treatment of subclinical hypothyroidism, there was no difference in the change in hypothyroid symptoms or in the study's tiredness scores. Furthermore, there was no beneficial effect seen in other outcomes, a quality of life measure, cognitive measures, blood pressure, weight, BMI, and waist circumference did not change significantly more in the levothyroxine treated patients than placebo. An assay of living activities, daily activities, was no difference. And although the study was not powered for cardiovascular outcomes, no difference in non-fatal or fatal cardiovascular events was seen either. Now, in another study looking at the issue of whether depression is associated with hypothyroidism, this study by Kim examined this potential relationship in almost 250,000 middle-aged adults who were followed for 2 years with a depression score. Depression, not surprisingly, was identified in about 3% of patients. But the multivariate adjusted hazard ratio for incident new depression was no different in the subclinically hypothyroid versus the euthyroid participants. And among those who were euthyroid, there was no association of depression with the level of thyroid hormone within the normal range. In related mood work, in this reported ancillary study from the TRUST trial I just described, depressive symptoms were determined in 427 of their participants before and after 12 months of either assigned placebo or levothyroxine. And as you see here, symptoms did not differ between these two therapeutic groups. No greater improvement in mood among those treated with TSH normalizing levothyroxine. And when these investigators compared their findings in the TRUST trial to those in 5 previous trials examining the response to thyroid hormone therapy in depressed patients with subclinical hypothyroidism, you can see that those trials also showed no benefit of treating subclinical hypothyroidism. Well, what about the issue of progression to overt hypothyroidism as an indication for thyroid hormone therapy, especially in patients with serologic evidence of underlying autoimmune thyroiditis? In this study from 30 years ago by Parle, 1,200 older patients with an elevated TSH and normal free T4 were followed for 12 months without intervention. 18%, 1 out of 6, progressed to overt hypothyroidism, and predictors of that progression were an initial TSH greater than 10 or positive thyroid peroxidase antibodies. However, in this trial, 6% of patients reverted to a normal serum TSH. All of those patients presenting initially with modest TSH elevation in the 5 to 10 range. Similarly, this study by Diaz, published more than 15 years ago, looked at the outcome in 107 patients over 55 years of age with no previous thyroid history who were newly diagnosed with subclinical hypothyroidism. And in this group, 37% had spontaneous TSH normalization over 1 to 6 years of follow-up, including almost half of those with subclinical hypothyroidism associated with TPO antibodies. So recent work suggests that subclinical hypothyroidism is often not a one-way street toward further thyroid failure. Predictors of progression in these and other studies are older age, women, patients, as in the PARL study with TPO antibody measurements, and the height of the serum TSH concentration with patients whose TSH is greater than 10 at significantly greater risk of progression than those in the lower 5 to 10 range. Finally, let's look at the postulated cardiovascular risks, ischemic heart disease and heart failure events and mortality that have been purported to be associated with subclinical hypothyroidism. There have been a number of prospective studies over the past 40 years, and these have, as you can see here, yielded variable results when looking at whether patients with subclinical hypothyroidism are more likely to suffer incident cardiovascular events. A confusing picture when these studies are viewed individually. The work of Nicholas Rodundi and his collaborators has been extremely important in helping to define the cardiac and other risks associated with mild thyroid dysfunction. And most important among their work has been the work shown here, looking at the likelihood of incident coronary heart disease events in patients with subclinical hypothyroidism versus those with euthyroidism. And you can see that there is a barely increased risk of such events that does not achieve statistical significance in this study of tens of thousands of patients from these combined studies analyzed in an individual patient meta-analysis. Similarly, when the group looked at incident coronary heart disease mortality, there was also a marginally increased risk that again did not achieve statistical significance for the group of individuals with subclinical hypothyroidism. Now, this table summarizes the findings from Rodundi's numerous studies looking at the risks of coronary heart disease events and mortality, of atrial fibrillation and heart failure, of stroke and overall mortality in patients with subclinical hypothyroidism who have been stratified into those with mild subclinical hypothyroidism, TSH is in the 5 to 9.9 range, and patients with more severe degrees of subclinical hypothyroidism. And you can see that this provides a clue to the previous disparate study outcomes, with heart failure, stroke, and overall mortality all more common in more severe degrees of subclinical hypothyroidism, including patients with a TSH between 7 and 9.9, whereas individuals with mild subclinical hypothyroidism in the 5 to 10 range did not experience any of these adverse cardiovascular events. Now, this field has limited evidence arising from prospective interventional trials like the TRUST trial I described previously. You can see here this very interesting, relatively small study performed by RASV, in which 3,093 individuals with subclinical hypothyroidism were investigated in a controlled but not randomized manner. They were identified in general practices in the UK, and individual physicians and patients decided whether levothyroxine therapy would be initiated or not. And then RASV seized this opportunity to examine the incidence of ischemic heart disease events and mortality in the two groups of patients. You can see here that among patients 40 to 70 years old, there was no significant, a significant difference between the incidence of fatal and non-fatal ischemic heart disease events in individuals who were levothyroxine treated, here their cumulative incidence of these events, versus those who were untreated. This, I draw your attention, in patients who were 40 to 70 years old. In contrast, RASV examined also the patients who were more than 70 years old, in whom you can see from this p-value whether or not patients were levothyroxine treated led to no difference in the incidence of these ischemic heart disease events, leading to the potential explanation that treating subclinical hypothyroid in middle-aged and younger or older adults may have efficacy, whereas treating the truly elderly does not. So in conclusion, with regard to subclinical hypothyroidism, TSH elevation with a normal free T4 may reflect thyroid failure or can be a part of the normal elderly state. Nonspecific symptoms, mood disorders, decreased qualities of life are not reliably relieved by thyroid hormone therapy. Many patients with subclinical hypothyroidism do not, in fact, progress. Even those with autoantibodies may revert to normal, particularly when their TSH is less than 10. And finally, there appears to be increased risk of cardiovascular events in middle-aged adults with subclinical hypothyroidism, but this has not been shown in the more elderly. Well, let's turn our attention in the time remaining to subclinical hyperthyroidism. I want to remind you of the potential pitfall in diagnosing this condition of racial differences in the TSH reference range. You see here from our NHANES 3 study in the US, the reference ranges for individuals with no history of thyroid disease, thyroid-related medications, or thyroid autoantibodies among Blacks and whites. And you can see that the reference range, the 95% confidence limits for Blacks extend lower than for whites. And that, in fact, a serum TSH of 0.3 or even 0.25 may be entirely normal in Black populations. I think a very important fact for endocrinologists practicing in places where there's racial diversity, like in the Gulf. Now, among the causes of subclinical hyperthyroidism, it is medical care that bears much of the responsibility. Here you see 4 clinical trials and epidemiologic surveys of levothyroxine-treated patients with hypothyroidism. And the prevalence of approximately 20% in all of those trials of patients who have been over-treated and whose iatrogenic thyrotoxicosis places patients in the subclinically hyperthyroid range. In addition, mild Graves' disease and autonomously functioning thyroid nodules can lead to this state. In the differential diagnosis, we need to keep in mind that biotin supplements can alter TSH assay measurements and lead to apparent subclinical hypothyroidism. And of course, that patients with hypopituitarism may have central hypothyroidism that is mild with a normal free T4, but a lower TSH. The potential indications for treating patients with subclinical hyperthyroidism are shown here. Symptoms, particularly insomnia and anxiety associated with thyroid hormone excess, their risk of progressing, especially when the TSH is less than 0.1, cardiovascular risks, bone mineral loss, and cognitive impairment. Let's focus here on cardiovascular consequences. And here you see the well-documented alterations in functional performance by the heart among patients with subclinical hyperthyroidism, whether exogenous due to thyroid hormone therapy or endogenous, with virtually all studies showing an increase in heart rate, systolic function, increased contractility, diastolic dysfunction, stiffness, and altered lusotropic relaxation. Many studies showing an increase in left ventricular mass, and at least for exogenous hyperthyroidism, alterations in exercise capacity. These are the cardiovascular disorders that have been associated with subclinical hyperthyroidism. And let's look at the data for first atrial fibrillation. These are the findings of Professor Clark Salwin from the Framingham trial, in which he looked at participants' serum TSH concentration at age 60, and then without therapeutic intervention, looked at their incidence of AF until age 70. And you can see here that 11% of individuals with a normal TSH went into AF between age 60 and 70. In contrast, among those Framingham participants whose TSH was less than 0.1 at age 60, 28% went into atrial fibrillation by a decade later, a 3.3-fold increased risk of AF associated with this mildly hyperthyroid state. It's interesting as well that the Framingham study showed that intermediate low TSH concentrations yielded an intermediately increased AF risk. With Dr. Ann Coppola, we showed the same thing in the cardiovascular health study. And you can see here that subclinical hyperthyroidism produced a cumulative incidence of AF that was twice that seen in patients with euthyroidism. Another early alarming signal that subclinical hyperthyroidism could have serious consequences arose from the work 22 years ago of Parle, who looked at almost 1,200 UK residents 60 and older, not on thyroid medication, and assessed their 10-year mortality, stratifying them by their low TSH or normal TSH concentration, with subclinical hyperthyroidism present in 6%. And you can see that here, cardiovascular survival, mortality reflected in a steeper slope, that mortality was 3.3 times more likely among patients with a TSH less than 0.5 milliunits per liter in comparison with UK residents who had a normal serum TSH. Here are three large studies summarized in a nice review by Professor David Cooper and Bernadette Biondi in the New England Journal of Medicine in 2018. Three studies that examined the risk of cardiovascular events in subclinical hypothyroidism versus euthyroid controls. Here, they again stratified patients into severe subclinical hypothyroidism and those with lesser degrees of TSH suppression. And you can see that cardiovascular events in the Scottish experience was significantly higher in both groups. That in the Danish study of more than 500,000 citizens, there was an increase in cardiovascular events among both mildly and at the borderline more severely hyperthyroid subjects. And finally, that similarly in the Colette study of 22,000 subjects from 6 cohorts, there was a significant increase in events among patients whose serum TSH was low. If we look at the issue of heart failure, similarly, the large Danish experience showed an association of both mild and severe subclinical hyperthyroidism with heart failure risk. And the study by Genser showed increased heart failure significantly more common among patients with severe subclinical hyperthyroidism. Now, in terms of mortality, the Colette study examined mortality and found it to be higher cardiovascular mortality in patients with severe subclinical hyperthyroidism, like the earlier Parle study. And remarkably, both the Selmer and Colette large trials found an increase in overall mortality among patients with both mild and severe subclinical hyperthyroidism. Another issue, as we all know as endocrinologists, related to subclinical hyperthyroidism is the risk of bone mineral loss as a result of accelerating this cycle of bone turnover. When bone turnover accelerates, bone loss predominates. And here you see the altered bone mineral density in a cross-sectional set of studies of patients with subclinical hyperthyroidism versus those with euthyroidism, with a combined size effect showing a significant decrease in DEXA-determined bone mineral density. Fracture risk has also been shown to be significantly greater in patients with subclinical hyperthyroidism. Here, among more than 70,000 participants in 13 prospective cohort trials, patients with subclinical hyperthyroidism during 750,000 person years of follow-up were shown to have greater risks of hip, of spine, of any fracture, and of non-spinal fractures at the borderline when they were subclinically hyperthyroid. And for particularly patients with severe subclinical hyperthyroidism, TSH less than 0.1, you can see that the risks of hip fracture, any fracture, and spine fracture were almost 1.5 to 3.5 fold greater than those who were euthyroid. These risks were obviously adjusted for other fracture risk factors. And interestingly, no association between subclinical hypothyroidism and fracture was seen. So in closing, we can conclude about subclinical hyperthyroidism that minimal TSH suppression with a normal free T4 may reflect mild hyperthyroidism in the cardiac conducting system and bone. Strong evidence relates subclinical hyperthyroidism to atrial fibrillation. There's moderately strong evidence relating it to heart failure and to both cardiovascular and overall mortality. Strong evidence relates subclinical hyperthyroidism with decreased bone density and increased fracture risk. And in data I don't have time to show you today, moderately strong evidence relates subclinical hyperthyroidism to dementia. I want to leave you with what I think is an elegant set of recommendations in the Cooper-Biondi review about which patients with subclinical hyperthyroidism ought to be treated. Older patients and patients with more severe degrees of TSH suppression. Here they recommend for patients over 65 and less than 0.1 that they ought to be treated, and that patients greater than 65 with a TSH and less than 0.1 really must be treated. So age and intense TSH suppression alone being probable indications for therapy, and the presence of both a mandate for therapeutic intervention. Well, it's been a pleasure, as always, to join you, my friends in the Gulf this morning, and I send you all my very best wishes from Baltimore. Goodbye.
Thank you so much, Dr. Leidenson. This was a nice overview, a comprehensive one about hyper and hypothyroid subclinical conditions. So we move on to the next speaker, and I will leave the floor now for my colleague or am I supposed to present him? Probably Dr. Tariq Nasser will be presenting the next speaker. The floor is yours, Tariq. The next speaker for this evening session, and it will be presented by Dr. Ali Al-Azharani from Saudi Arabia. He's a professor of medicine and endocrinology at King Faisal Specialist Hospital and Research Center in Riyadh, and he's going to be talking about risk certification of differential thyroid cancer. So the floor is yours, Dr. Ali.
Rahim, thank you so much for the opportunity to talk to you today about risk stratification thyroid cancer. with an emphasis on clinical implication. My name is Ali Zahrani. I'm from King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. And I would like to thank the Arab Thyroid Association for this opportunity to talk to you about this subject. I have nothing to disclose. So as we all know, thyroid cancer has been increasing over the last 30 to 40 years, and this increase is probably related to a great extent to the widespread use of ultrasound and other imaging techniques. This data is from Sears data in the United States, but more or less a similar pattern is seen everywhere. However, when we look further at the specifics of this increase in incidence, you'll find that most of this happened in small thyroid cancer size less than 1 centimeter. You can see also that size between 1 to 2 centimeter has been also increasing, but less steeply. And then you see even more even increase in the thyroid cancer incidence in the size 2 to 5 centimeter. And in tumors more than 5 centimeter, the incidence has been steady over the last 40 years. Now, most of those cancers, as you can see here, is less than 1 centimeter, almost 50% of them, and almost 90% of them less than 2 centimeter. So in reality, large tumor occur in only around 10 to 15% of patients. So with that, one can conclude that thyroid cancer is common as an increasing in size. In incidence, most cases are small tumors of lower stage and carry small risk for mortality, and that only 10 to 15% are high grade and carry significant risk of recurrence and mortality. Therefore, it's clear that we need a system to filter out high risk from low risk thyroid cancer and manage that accordingly. And that's where risk stratification has come into play. This is a review article that I had the honor to write it with Dr. Tuttle, who is more or less the father of this risk stratification in the last 10, 15 years. And this is the journey of a thyroid cancer patient. So as you all know, thyroid cancer patients comes with nodules, and then we diagnose them. They go for surgery if they have cancer. Sometimes we give them radioactive iodine and thyroid hormone suppression, and then we follow them up through their journey. Risk stratification is an active process that is done at multiple stages in this journey. It starts actually at the time of diagnosis. When the patient presents with thyroid nodule, we actually assess the risk of this thyroid nodule and decide whether it needs FNA or not. And then when we diagnose thyroid cancer, we ask ourselves whether this patient can be actively surveyed or what is called minimalistic management. And if not, whether he needs lobectomy or total thyroidectomy. The patient goes for surgery, we see them, and then we assess their risk based on the pathological findings. And we used at this stage 2 systems, the AJCC 8th edition TNM staging and the ATA risk stratification to estimate their risk of recurrence or persistent disease. Based on this, we decide whether to give them adjuvant therapy, how much of thyroid hormone suppression we do, how frequent we follow them up. And then during the follow-up, we use a different system. We use response to therapy, or what is called dynamic risk stratification. Basically, we classify those patients in excellent response, biochemically incomplete, structurally incomplete, or indeterminate. And I will discuss these things in some details. So I'm not going to go into details about how to evaluate and risk stratify thyroid nodules. You are all familiar with this, but as you can see here, we have high risk, intermediate risk, low risk, very low risk, and benign based on the ultrasonographic features. This is the American Thyroid Association pattern recognition. And we have another system that is also widely used, ThyRAD system. And in all of these systems, it is a matter of risk stratification. We are basically looking at the ultrasound, looking at specific features, including composition, echogenicity, shape, margin, and deciding how much risk for malignancy is in this specific nodule, and decide what is the next step. So as I mentioned, in addition to deciding on FNA, we decide on whether to do active surveillance or not. And since this is not widely practiced in our region, I'm not going to discuss it. However, I'm going to discuss what type of surgery if we diagnose a patient with thyroid cancer and we decide that he or she will need surgery. We use, like many, almost universally, people follow the American Thyroid Association guidelines and other guidelines, and the question whether to do total thyroidectomy or hemithyroidectomy or lobectomy, and that's again based on the risk stratification. So this is the recommendation from the American Thyroid Association. I think nobody would disagree that a near total thyroidectomy is needed for patients with large tumors, more than 4 centimeters, especially when they have gross extrathyroidal extension, or when there are lymph nodes or distant metastases. The choice is variable between total thyroidectomy or lobectomy for tumors that are between 1 to 4 centimeters, and having no extrathyroidal extension and no lymph node or distant metastasis. And I think that makes sense. If you look at the features of those, the risk for this type of patients is not that high. And then lobectomy is advised and indicated and recommended for tumors that are small, with no extrathyroidal extension, no lymph node metastasis, and when they are unifocal intrathyroidal, in the absence of history of head and neck irradiation, familial thyroid cancer, or clinically detectable cervical lymph node. And again, this is a common sense recommendation. I'm not going to discuss the lymph node metastases and how to handle them, because this is covered in another lecture in this conference. So the patient already had surgery and comes to us now after surgery, usually 6 to 8 weeks later. And now we want one more time to assess his risk long-term, his risk of death from his cancer and his risk of getting recurrence from cancer. And these are the two systems that are widely used, the TNM staging and the American Thyroid Association staging system. And their use is mostly in the post-operative period here, because based on the risk, we decide whether to give a patient radioactive iodine and how much of thyroid hormone suppression is indicated. So again, just to emphasize that the American Thyroid Association risk classification predicts risk recurrence, and TNM AJCC 8th edition is for predicting death. This is the TNM staging. It is a bit complicated, especially for patients more than 55 years of age. The patients are classified in those more than 55 and less than 55 years of age. For the group less than 55, it's very easy. If they don't have metastases, they are stage 1. And if they have metastases, they are stage 2. For those more than 55, we look at the lymph node, the extrathyroidal extension, the tumor size, and I'm not going to go into the details. But I can say, as you can see in this study and several other studies, that this system is an excellent system for predicting mortality. You can see patients with stage 1, they enjoy 99% survival long-term. And those with stage 2 also enjoy very good survival of around 96%. But as we move to stage 3 and especially stage 4, the mortality increases. So the risk of mortality for stage 3 overall is around 20%, and for stage 4 is around 40%. Now, that's the TNM that predict mortality. What about recurrence, which is much more common than mortality? Mortality is rare in thyroid cancer, so most of the time we're concerned about recurrence. The American Thyroid Association started this risk stratification system in 2009 and refined it further in 2015, and it is now the most widely used system. And this system is a continuum, as you can see here on the right side. However, they have kept 3 classes of risk: low risk, intermediate risk, and high risk. So the low risk is basically intrathyroidal tumor, and sometimes we allow up to 5 lymph nodes, provided they are small, less than 2 millimeters. The high risk is patients with gross extrathyroidal extension, incomplete tumor resection, distant metastases, or lymph node more than 3 centimeters. And anything in between, including aggressive histology or minor extrathyroidal extension of vascular invasion, is classified as intermediate risk. This system has been validated in the 2009 system has been validated from many parts of the world. You can see here that low risk patients enjoy very high cancer-free survival, while when you go into the intermediate, these numbers decreases somewhat, and then those with high risk, they're rarely cured, and you can see that most of them will continue to have a disease. Structural disease, on the other hand, is rare in low risk, more common in intermediate, and most common in high risk. So this is clearly working. This is another study that was published recently. It's a prospective study from Italy, including more than 2,000 patients in 40 Italian centers. And without going to the details, I just want to show you here on the right side that the low risk is the majority, and only 1.5% of them continue to have structural persistent disease. When we move to the intermediate risk, it's around 6%, and most recurrences occur in the high risk is 14.5%. So this system works quite well. And we utilize it mostly for deciding on whether to give the patient radioactive iodine or not, and how frequent to follow those patients, and how much thyroid hormone suppression to be used. So for low-risk patients, for most part, we don't give them radioactive iodine. As you can see here from the recommendation from the ATA, no or not routine, so we rarely give low-risk patients radioactive iodine. On the other hand, we definitely give every patient with high-risk disease radioactive iodine, and high-risk disease, as you can see here, is patients with gross extrathyroidal extension or distant metastases. I think the problem is the intermediate group, and this is left to the judgment and the experience of the physician. So as you can see, the recommendation here is consider taking into consideration the features of the tumor. Okay, the patient had surgery, received radioactive iodine or not, and is on thyroxine and is being seen on a regular basis, usually every year. Now, all these previous systems, the ATA and TNM, loses their significance, and now it is much more important to depend on the response to therapy or dynamic risk stratification. So to illustrate the point, look at this case. This is a 32-year-old lady who had classical type of papillary thyroid cancer. She has T3 tumor N1B, so she has lymph node, but no distant metastases. By the American Thyroid Association, she is an intermediate risk. And by TNM, she is stage 1 because she is young and has no distant metastasis. She received total thyroidectomy and radioactive iodine. So again, she is at this place in the American Thyroid Association. Her risk of recurrence is around 20%. And she is stage 1, so her risk of mortality is extremely low, but her risk of recurrence is around 20%. She was treated. She is coming to you now 1 year later. Ultrasound is negative. TG is undetectable, and stimulated TG is undetectable. Now, this patient is an excellent response, and her risk of recurrence is extremely low. If we take the same patient, exactly the same features, so she has again 20% chance of risk, and she's stage 1, has very minimal risk of mortality. But she comes to you one year later. She has several lymph nodes, Her thyroglobulin on thyroxine is 55. CT scan is showing bilateral metastasis. This patient now is not in remission. She is not in excellent response. Her risk of she's already having persistent disease, and her risk of mortality is quite significant. And that's why this system is very helpful in deciding what is the next steps. This is called dynamic risk stratification or response to therapy status, and it classifies patients into excellent response, biochemically incomplete, structurally incomplete, or indeterminate response. This slide is a courtesy from Dr. Tuttle. And again, excellent response is no clinical, biochemical, or structural disease. Biochemically incomplete is when thyroglobulin is elevated or thyroglobulin antibody is rising, but you cannot find a disease on imaging. And structural disease is when you find a disease on imaging or on FNA, so the patient has persistent or newly identified locoregional or distant metastases. And there is a group that is not clear. They are not absolutely having excellent response, and they are not also having biochemical disease. So they have non-specific biochemical, slight elevation in thyroglobulin or thyroglobulin antibody being positive, and they don't have structural finding. So we're not sure if they are in remission or they have a disease, and we call them indeterminate response. This system was studied several times. This is how we define it. Probably for the sake of time, I'm not going to go into details, but there are specific definitions for the TG level and for this imaging techniques. So let's just look at this one. When the patient has total thyroidectomy and iodine 131, to call him excellent response, in excellent response, TG should be less than 0.2 in the absence of antibody. And if it is stimulated, it should be less than 1. TG antibody should be negative, and imaging, ultrasound, and other imaging when done is negative. This is excellent response. The risk of recurrence is at most 4%. Biochemically incomplete is TG more than 1, TG stimulated more than 10, negative antibody, and imaging is negative. Indeterminate is between 0.2 to 1 or stimulated 1 to 10 antibody, or when there is rising antibodies, or the imaging techniques is showing non-specific finding. And structurally incomplete is clearly metastasis on CT scan or PET scan, or FNA is positive. There are other definitions for patients who had only total thyroidectomy or lobectomy. Again, for the sake of time, I will not have time to go into the details, but I want to show that this system predicts recurrence very well. So if a patient is in excellent response, his risk or her risk of recurrence is maximum at 4%, 1 to 4%. So most of them will enjoy long-term remission. For indeterminate category, again, around 90% will enjoy no evidence of disease. Only around 15 to 20% will have recurrence. The same for biochemically incomplete. The majority, around 70% actually, will have a remission or no evidence of disease long-term. But around 20% will have biochemical recurrence, will continue to have biochemical incomplete status, and similar percentage will have actually structural disease. The problem mostly is in patients who have structurally incomplete response. Those are patients who are already having a disease, so their long-term cure is less than 15%. Most of them continue to have either indeterminate response or biochemically incomplete response, structural disease, or even death. You can see the mortality in this group is up to 40%. So you can see that this system works very well in predicting the long-term outcome. And for that reason, this has implications on the management. If the patient is in excellent response, he is likely to continue to enjoy that remission status, and the recurrence is very low, and therefore you don't have to struggle so much to see this patient. You can decrease the intensity and frequency and follow-up of this patient, decrease the degree of TSH suppression. If the patient has biochemically incomplete response, he has around 20% of structural disease. And therefore, obviously, we'll be watching those patients more carefully than the first group. However, we will not, most of the time, we will not interfere unless we see a disease or rising antibody or TG antibodies. Structural disease is clearly structural disease. This is a persistent disease or recurrent disease that is the most worrisome. And those patients usually require additional treatment and can be followed more closely. And intervention is done when necessary. The indeterminate group is, for the most part, is a low-risk group. And again, we continue to observe those patients with mild suppression and interfere if there are signs of recurrence of the disease or progression of the disease, like, for example, rising TG or TG antibody, or appearance of some structural finding on ultrasound or other radiological studies. For patients who had only lobectomy, TG is not that helpful. I mean, it is not going to be undetectable. However, stable thyroglobulin is very helpful. Patients usually who have recurrence will have an increasing thyroglobulin level. We keep an eye on them. Those patients, to start with, are low-risk patients. Otherwise, we would not have done lobectomy. We keep their suppression mild. And then we follow those patients basically every 6 to 12 months initially. And then we do ultrasound, we do serum thyroglobulin every 6 to 12 months, usually for the first 3 years. And then we decrease the frequency. When do we do completion thyroidectomy? If there are findings on the physical examination or ultrasound, or we think that they need radioactive iodine, or the thyroglobulin continue to rise significantly. We have done several studies actually on the risk stratification system. So we started actually with the comparison of the 7th edition of TNM with the 8th edition. And we found, like many others, that the TNM 8th edition downstage many patients, especially in stage 3, because extrathyroidal extension, minimal extrathyroidal extension in the past in the TNM 7 was enough to classify patients as stage 3, but it's no more in TNM 8. So most patients went back to stage 1 or stage 2. And you can see even that TNM staging was cleaner when in terms of predicting disease-free survival. You can see good separation between the different groups compared to TNM 7. And it's even better for cancer-specific survival. You can see TNM 7 lumped everybody in this area, but TNM 8 separated different stages nicely. We looked at predictors of recurrence in patients. We looked actually on the usefulness of status or response to therapy status, or what is called dynamic risk stratification in thyroid cancer. This is a complicated table that I would just show you the results. Basically, patients here at 12 to 18 months who were in excellent response continue to be in excellent response, who were in biochemically incomplete, indeterminate, continue to be mostly in indeterminate status. Some of them had biochemical recurrence. And then patients with biochemically incomplete, some of them develop structural disease. And those with structural disease continue to have structural disease. So the basic thing is that the response to therapy status predict the long-term outcome. And the overall follow-up here was around 7 years. The median follow-up was 7 years. We looked at predictors of response in patients with low and intermediate risk thyroid cancer. And as you can see, the American Thyroid Association in our patients predicted very nicely the disease-free probability or disease-free survival. This is low risk. This is intermediate risk. So as expected, low risk did very well, intermediate less well, but again, very well. And you can see the predictive factors basically in multivariate analysis. We found age and iodine and lymph node metastases to be predictive of long-term outcome. Let me skip some slides here because time is pushing me. But again, we looked at predictors of long-term remission in intermediate and high-risk group. And we excluded patients with low risk. So we focused on around 300 patients with intermediate and high-risk differentiated thyroid cancer. And as you can see here, the American Thyroid Association predicted nicely the long-term outcome. This is the intermediate group. This is the high-risk group. The age was predictor. Distant metastases were predictor, and tumor size was a predictor. And here we looked at age for the intermediate group alone and age in the high-risk group, and it was predictive of long-term outcome. This was shown also in other studies from other centers. This is from Memorial Sloan Kettering Institution. And you can see that age was important in the high-risk group. So patients who are older than 55 had more structural disease than those who are less than 55. By contrast, patients who are less than 55 had more excellent response than those who are more than 55. Another study from Australia suggested that adding age, and I will just pass through this, but the conclusion is that adding age and adding serum thyroglobulin, and extrathyroidal extension, which are not part of the American Thyroid Association, improve the American Thyroid Association outcome. This is a study from Italy, recent study, I think last month published in JCEM. And again, they added many variables to the American Thyroid Association variables, including even some demographic features like body mass index, the circumstances of diagnosis, and many others. And they basically concluded that adding those features that are not part of the American Thyroid Association improves the predictability of the system. I was asked actually to write an editorial on this, and I put this title, The Risk of Expanding Risk Stratification in Thyroid Cancer, meaning basically that we don't want to expand so much so we lose the practicality of the system. So in conclusion, thyroid cancer is remarkably increasing in incidence. Most cases are low risk for recurrence and mortality, but a significant portion can be of high risk causing morbidity and mortality. It's around 10 to 15%. And the risk stratification is the way to filter those patients out and to manage them differently. Risk assessment is a dynamic process. Low risk needs minimal intervention. High risk needs very proactive approach. And patients in the intermediate risk need to be individualized based on different features and characteristics of those patients. Risk, as we just mentioned, is a continuous process and it's a dynamic process. And again, I want to emphasize the American Thyroid Association risk stratification is an excellent system for predicting recurrence. And the TNM is an excellent system for predicting mortality. Response to therapy is an excellent system to predict recurrence and mortality during the follow-up. With that, I stop here. Thank you so much.
Well, thank you, Dr. Zahrani, for this beautiful presentation on the risk stratification of thyroid cancer. And the next speaker would be again Professor Paul Ladenson, who's going to be talking to us hopefully for the coming 15 to 20 minutes on unusual thyroid function test interpretation. And the floor is yours, Dr. Ladenson.
Good morning again. We're going to have some fun with some cases of challenging thyroid function tests. Our objective is to define the approach an endocrinologist should take when a patient has discordant serum thyroid hormone and TSH values. All such cases, I believe, can be figured out by asking oneself these 4 questions. Could the findings be explained by a temporary disequilibrium in the HPT axis? Could they be explained by an inherited or acquired abnormality in the plasma transport of thyroid hormones or of TSH binding? Could the findings be explained by a rare form of thyroid dysfunction? Or could the findings be explained by laboratory interference in hormone measurement? Our first case is a 134-pound woman with treated hypothyroidism who's currently taking 175 micrograms a day. But despite that, as you can see in her yellow highlighted current thyroid function test, has a high TSH of 7 despite a high normal free T4 of 20. What explains this odd set of results? The first question answers this case's conundrum. Could the findings be explained by temporal disequilibrium? This shows you a study I performed as an endocrine fellow looking at how patients with overt hypothyroidism given levothyroxine intravenously daily had changes in their T4 concentration and TSH. And you can see while total T4 rose by 1 microgram per deciliter per day, TSH fell by only 50% at the end of the week. So this patient's discordant TSH is the result of intermittent non-compliance. In other words, in anticipation of her upcoming appointment, she started taking her medication again in time to normalize her free T4, but not the TSH. Clues to this can, as in her case, be past nonsensical serial thyroid function tests, like a more suppressed TSH on a lower levothyroxine dose in the past, and also by an unexpectedly high T4 dose requirement, which is the result of such intermittent compliance and the testing results it leads to. Here's a second patient, a 29-year-old woman whose hyperthyroid Graves' disease was treated in January. And here you see her serial serum thyroid function tests over the next 3 months. Her free T4 initially remaining elevated and then falling into the low range, but with a persistently low serum TSH concentration. In fact, finally, in May of this year, her serum TSH concentration rose. How did this odd set of thyroid function tests in April with a low free T4 and a low TSH occurred? Well, this was explained in an observational study by Mary Samuel's group, who looked at a group of 21 patients with radioiodine-treated Graves' disease and found that they often had transient central hypothyroidism. In other words, a persistently suppressed TSH that took a mean of 63 days after normalization of the free T4 following radioiodine therapy to wake up. Low free T4 and TSH with a low TSH persisted due to this disequilibrium in the hypothalamic pituitary thyroid axis. The second question we should always be asking is, could the findings be explained by an abnormality in plasma transport of thyroid hormones? It's illustrated by this 49-year-old woman whose 18-month history of nonspecific symptoms were accompanied by a low normal TSH, but an elevated serum total thyroxine. The clue to her problem was her 6-year history of primary biliary cirrhosis. As we know, thyroxine and T3 are bound to 3 classes of plasma proteins, the most important of which is thyroxine binding globulin, accounting for 70% of iodothyronine binding. And you can see this patient's slightly low TSH with follow-up testing and elevated total T4 was in fact associated with a lowish free T4 concentration by immunometric assay and confirmation of an elevated thyroxine binding globulin. The result, as we all recognize, of her liver disease and leakage of TBG from the liver. TBG excess can be caused by an inherited X-linked genetic alteration, by estrogen-induced change in the form of TBG, making it more heavily glycosylated and slowly cleared due to, as in her case, hepatitis, a number of drugs, and for reasons that remain unclear, acute intermittent porphyria. Here's another case of a T4 treated patient who had post-ablative hypothyroidism after a history of hyperthyroidism 11 years ago. She's taking a lowish dose of levothyroxine, 75 micrograms a day, and has an elevated TSH, but the puzzling part is that her total T4 is elevated. And in fact, her free T4 by IMA is also elevated, and the calculated free thyroxine index is also elevated. How do we explain in this patient on a relatively low thyroxine dose this inappropriate TSH for a high measured free T4? Well, the gold standard measurement of free T4 measurement is equilibrium dialysis, and you can see that, in fact, returned low. This is a patient who proved to have familial dysalbuminemic hyperthyroxinemia, something that can be an autosomal dominant trait due to an albumin species that has been mutated to have increased T4 binding capacity. And it yields exactly the kind of thyroid function test picture we just saw, an elevated total T4, an elevated free T4 immunoassay, and elevated free thyroxine index, but a dialyzable free T4 that's normal. This diagnosis can be nailed down by ordering a T4 binding protein panel from Quest. And here you see, in comparison with the protein electrophoresis of radiolabeled T4 in a normal individual, the elevated albumin-bound T4 fraction present in patients such as this with a dysalbuminemic hyperthyroxinemia. I want to remind you as well that there's a similar derangement in pre-albumin transthyretin that can lead to increased T4 binding. Here's another puzzling case, a woman with treated hypothyroidism due to Hashimoto's thyroiditis who's taking a reasonable dosage of L-thyroxine for her weight, has a normal TSH, but an elevated total T4, an elevated free thyroxine index, and then a puzzlingly low free T4 concentration by immunometric assay. TPO antibodies were present as one would expect with Hashimoto's disease. This is the classic picture of hyperthyroxinemia due to a T4 antibody, something described in patients with chronic autoimmune thyroiditis, and more rarely antibodies against T3. Most patients with this syndrome remain euthyroid unless their underlying autoimmune thyroid disease causes thyroid dysfunction. And it does exactly what it did in this patient, a spuriously elevated total T4 and RIAs, and of the calculated free T4 and free T4 index, but a low free T4 immunoassay. That's the tip-off to this derangement. Other causes of elevated total and free T4 include, as you know, certain medications altering T4 to T3 conversion, iodinated radiocontrast dye, amiodarone, and high doses of beta blockers, acute psychosis, amphetamines, and high altitude, along with hyponatremia, being mysteriously reported causes of hyperthyroxanemia, and also some patients on levothyroxine replacement having T4 values that bracket the upper limit of normal despite a normal TSH. We always need to remember in discordant thyroid function tests the possibility of a rare form of hypothyroidism. Here we see the typical free T4 and TSH values in hypothyroid and hyperthyroid patients. And we need to recall that in central hypothyroidism, the free T4 will be low with either low TSH, a normal TSH, or due to decreased TSH receptor binding, even a modestly elevated serum TSH. And also remember that patients who have an elevated free T4 with a normal or inappropriately normal or elevated TSH can potentially have TSH secreting pituitary adenomas, something revealed obviously by pituitary imaging and by measuring the alpha subunit, which is secreted in excess. This syndrome of TSH secreting pituitary tumors needs to be distinguished in clinically hyperthyroid patients from central resistance to thyroid hormone. And finally, in closing, endocrinologists also need to address in these patients the possibility of interference with laboratory measurement. Here's one that I'll bet you've seen in your own practice in recent years. A healthy patient noted on routine exam to have a high free T4 and low TSH with no symptoms of thyrotoxicosis, no history of thyroid disease, and this set of supplements, including biotin, this player, which we know can falsely decrease the serum TSH concentration. In this JAMA published study 6 years ago, lowering TSH by 0.7 to 1.7, with results often falling below the reference range, and then a troubling increase in measured free T4 induced by biotin, leading to the misperception, in this case, of subclinical hyperthyroidism. This can be avoided by stopping biotin 2 days before testing. So these 4 questions to remember in addressing confusing thyroid function tests. Could the findings be explained by a temporary disequilibrium in the HPT axis? Or could they be due to a rare form of hypo or hyperthyroidism? Could they be due to an inherited or acquired abnormality of plasma protein transport of thyroid hormones? Or could they be explained by laboratory interference? Thank you. Best wishes and goodbye.
Well, thank you, Professor Leidenson. This was a very interesting session, quite interesting cases related to abnormal thyroid function test. I think if we, I don't see any questions from the audience, and we are probably around 20 to 30 minutes behind in the schedule. So I was wondering if anyone would have a burning question to ask Dr. Al-Zahrani or Dr. Leidenson. We can take it now. Otherwise, we have to move on with our schedule to the next presentation. And if we don't have any questions from the audience, I thank you for your attention, basically, and we move on with the Congress. Thank you so much, everyone.